Before I begin, please allow me to thank the entire organizing committee, especially led by Dr. Tonin, for this noble endeavor of gathering us all together here to exchange experiences on teleneurorehab. And let's give a hand to the entire organizing committee. And we at the Department of Rehabilitation Medicine from the Philippines are very grateful for being given this opportunity to share with you our humble experience back in the Philippines. And we look forward to also learning from your experiences and hopefully bring something back home that could improve our practice. You see, the Philippines is composed of 7,107 islands. It's an archipelago located in the Southeast Asia. And in the Philippines, we have, at present, 104 million Filipinos. And this is catered to by about less than 300 physiatrists, according to the Philippine Academy of Rehabilitation Medicine. And according to the National Statistics Office, by 2045, it is estimated that we would have 142 million Filipinos. And with only 6 training institutions in the Philippines, all of which are located in the urban areas in Manila, we would have about less than 1,000 physiatrists by 2045 to cater to this growing number of Filipinos, and most of whom are actually located all over the country. Considering our geographical landscape, which is an archipelago, this is to be served by the physiatrists who are mostly located in urban areas. Hence, you can imagine the disparity, the growing disparity between the supply of and the demand for rehabilitation care in our country. So, this is on your left-hand side. This is just the facade of the National University Hospital in the Philippines, which we belong to. And on the right-hand side is an example of the landscape of the rural area in the Philippines. So why is it hard for people from rural areas and even urban areas in the Philippines to access rehabilitation medicine services? Well, there are a lot of factors hindering access to rehabilitation medicine. And as you may know, it is primarily because of the lack of manpower. As I have mentioned earlier, the growing disparity between the supply of and the demand for rehabilitation care is brought about by the lack of physiatrists, about 216 fellows, recognized fellows of the Philippine Academy of Rehabilitation Medicine, and at present, there are about 5,000 physical therapists in the country, about 3,500 occupational therapists, and about 500 speech therapists. Aside from the lack of manpower, there's also lack of access to a rehabilitation center. You see, most of the rehabilitation facilities in our country are located in the urban areas. And we also don't discount the fact that we have lack of financial or transportation capabilities for our fellow men back home. And the limitations due to disability can also hinder them from accessing rehabilitation medicine services. And another factor is the need to travel long distances and, of course, endure long hours of traffic in the Philippines just to get to the nearest rehabilitation facility. And there's also still the lack of knowledge of what rehabilitation medicine can offer in our country. There's poor compliance to outpatient therapy, caregiver fatigue, and lack of motivation for patients and the family. That's why we did community-based rehabilitation before. So this is an example. These are examples of a community-based rehabilitation setup. However, this was not sustained, primarily because of lack of manpower and, of course, financial constraints to sustain the program. Hence, we tried to think of other ways to deliver rehabilitation medicine services to the rural areas. And we were inspired by this rural health unit in Alfonso, Cavite, which is a small town in a province about 2 hours away from Manila, if not traffic, but it could get longer. And this is where our medical interns rotate in during their medical internship year. And every week, they would deliver outpatient consults to the people in the nearby communities. And one of the interns there, who was actually one of our students, referred to the Department of Rehabilitation Medicine regarding one of their patients. And that was the case of an elderly female with degenerative osteoarthritis who has been 2 months post-total knee arthroplasty. But even 2 months post-op, she was still having difficulty in functional mobility. And so we allowed her to refer the patient to us, and she presented the problem according to the WHO ICF format. And with these problems, we delivered the first telerehabilitation session, and we were able to help the patient gain functional mobility. That actually inspired us to take telerehabilitation further in our hospital at least. So we did focus group discussions and collaborations with the Department of Family and Community Medicine, National Telehealth Center, and the informatics or the information management system of our university. Then we did community visits and also trial runs or dry runs of the technical setup in the actual community of Alfonso Cavite in the rural health unit. So in front of the computer was the municipal health officer of the rural health unit, and the 2 other interns were interns from the University of the Philippines, and back there was the resident physician of the Department of Family and Community Medicine. They all helped set up the telerehabilitation session. And with that, we were able to deliver telerehabilitation sessions since then. And on one side was the setup of the telerehabilitation session in the community, and this is the telerehabilitation team in the Department of Rehab Medicine at the University of the Philippines, Manila. So we did service, we did training or educational benefits to the interns and also the doctors who were able to witness the telerehabilitation session. We did collaboration and linkages, and this also inspired us to do researches. So who are the participants in a 2-way telerehabilitation session, at least for our setup? Of course, the telerehab team, in every session, we had the physiatrists. We also had representatives from the different sections of the department, from PT, OT, speech, swallowing, rehabilitation, and also psychology, and even the nursing team. And on the other side is the telecommunity team. We have the municipal health officer, the resident physician who is rotating there from the Department of Family and Community Medicine, the barangay or the community health worker, and the community organizer, the patient, of course, and the family or caregiver. And we also have the medical interns rotating in the community. You see, the medical interns were asked to refer or telerefer their patients to us, but there seemed to be a gap because they were not prepared for the actual telerehabilitation session. This inspired us to incorporate telerehab in the curriculum. So the Department of Rehab Medicine proposed this curriculum to the College of Medicine of our university as a stepwise approach to telemedicine. As early as third-year medical students, they were exposed to what telemedicine in general is, specifically telerehabilitation, preparing them in terms of the physical setup and the facility of how telerehabilitation looks like. And when they reach medical clerkship in 4th year, they would be taught on the content and the technique of telerehabilitation and would be asked to simulate a case, telereferring a patient to a consultant using a telerehabilitation setup. And during their medical internship or 5th year of medical school, they would be asked to telerefer an actual OPD patient to a telerehab consultant. In that way, they would be prepared to do telemedicine or telerehabilitation sessions when they're licensed physicians already. So this is an example of the interns telereferring a patient to us. And on the other picture, we were verifying some physical examination findings using the virtual setup. So this slide shows the return demonstration of an actual patient from the community demonstrating the exercises that were previously taught by the therapists or the telerehab team on one side. When we started early on in 2015, we just began with the use of Skype because that was the most accessible teleconference, free application for us. And however, we tried to elevate our practice throughout the years by partnering with National Telehealth Center, which is housed in the University of the Philippines. And under its belt, there have been a lot of telemedicine programs already, the latest edition of which is telerehabilitation. And through National Telehealth Center, we were very fortunate enough to have been given this new equipment from Yonsei University, Seoul, South Korea. And with this new equipment, which has an encrypted software for teleconferencing, we were able to deliver telerehabilitation sessions safer and more efficiently. So if you're going to think about it, the Philippines actually has only 2.7 Mbps internet connection speed, in contrast to the global average internet speed of 4.5. So you might wonder how would we be able to deliver telerehabilitation with such a relatively slow internet connection rate. But let's not underestimate the power of Filipinos in terms of maximizing the World Wide Web or internet, because we are not tagged as the social media capital of the world for nothing. But you see, there's a gap wherein we're not sure if the Filipinos are able to translate such technological proficiency in producing useful health outcomes or in promoting health-seeking behaviors. Throughout the past 6 years, the internet has actually penetrated the homes of Filipinos, growing to up to 47.1% from previously 8.27% when it started. And according to the National Health Insurance Act of 2013, the present government actually endeavors to support the use of technology in the delivery of healthcare services, especially in far-flung areas, such as, but not limited to, telemedicine, electronic health records, and the establishment of comprehensive health database. So with the support of the government and, of course, the administration of our university, we have tried to review the telerehabilitation program strength. And we divide the strengths into the following areas. First, in terms of service, we were able to provide, by far, some telerehabilitation consults and follow-up care to patients in the community. And the top conditions that we have served include osteoarthritis, low back pain, and stroke. In terms of providing education to the students and even the doctors in the community, we were able to emphasize the role of telemedicine to future physicians. And since University of the Philippines is the national university hospital, and the students are actually government or the nation's scholars, there's this mutual agreement that after they graduate from med school, they should return the service by becoming doctors to the barrios or doctors to the communities. And as such, we train them as general physicians to be able to recognize the multidisciplinary approach in terms of care to their patients in the community. So they're able to recognize the need to refer their patients to us or to specialists in case there's necessity. And we were able to provide interactive educational benefits for doctors, students, patients, caregivers, and the community health workers, who are all our stakeholders. And we were able to provide education on the physiatric principles. In terms of administration, we were able to establish collaborations with the community. We were fortunate enough to have been a recipient of telemedicine equipment from Korea. We were able to improve workflow of telerehab. And we were able to gain cooperation from consultants in rehabilitation medicine in providing tele-rehab sessions. And we have been doing researches, and some of them are still underway. In terms of the weaknesses of our tele-rehab program at present, there's this low number of tele-referrals at present. On average, we receive about 2 to 3 tele-referrals from the community, primarily because there's only one community at present that's our partner for tele-rehabilitation. Because you see, we had to do feasibility studies in order to ensure sustainability of our program. So we also have to train the community health workers in using the system that was, for example, donated by the university in Korea. And we have to also establish the list for eligibility criteria to help the health workers identify who needs to be referred for tele-rehabilitation. And there's lack of follow-up and the low participation of paramedical professionals from the hospital side because, of course, there's already heavy workload on top of the tele-rehab duties. Now, in terms of education, there's the lack of tele-rehab consultants willing to teach virtually. And of course, that could be brought about by lack of acceptance, probably, and lack of training for the tele-rehabilitation approach. There's insufficient staff training and the lack of established protocols, at least in our present setting. In terms of administration, there's this cost of implementation that we have to consider. There's no reimbursement for consultants who deliver tele-rehabilitation sessions. There's lack of technical support. The data privacy issues are also a consideration for some, and the lack of local international linkages. And we still have to do more researches on specifically these areas to prove its effectiveness in our setting. Nonetheless, in terms of the feedback we gathered from the different stakeholders, they found that tele-rehab is innovative. It's an excellent breakthrough in community-oriented medicine and a bridge between community and rehab medicine. The lessons the students at least learned from participating in tele-rehab sessions included the following: that patient care in tele-rehabilitation setting is feasible, and it was creative in doing usual evaluation and treatment in a virtual way. And they were taught about exercise prescription using the tele-rehabilitation approach. And down the line, they were even able to learn some special musculoskeletal examinations using tele-rehab. The challenges, however, were the internet connection lapses, difficult navigation of the camera, and some students expressed difficulty in eliciting special tests during physical examination. Nonetheless, according to this survey that we had from the different stakeholders, they found that the experience with tele-rehabilitation was excellent, and they highly recommended that tele-rehabilitation be continued. And lastly, in terms of our future directions, we plan to list eligibility criteria for tele-referrals, and we would like to promote tele-rehab to other communities by first, of course, doing feasibility studies in these communities who have already expressed interest in participating in tele-rehab. In terms of education, we would like to revisit the curriculum and also train more consultants for the tele-rehab. And in terms of administration, we want to ensure privacy of patient data through encrypted softwares, learn from international experiences, and establish linkages. And lastly, in terms of research, probably we could come up with some detailed research agenda that our students and also our consultants could pattern their research ideas after in order to make our researches in line with international standards. And we need to conduct more local researches and publish them, and look for government and or private funding agencies with interests in telemedicine. So with that, thank you very much for your kind attention.
Thanks a lot for your very interesting presentation. So we have 5 minutes for questions, and I would like to be the first, asking you, in which kind of patient do you think this is the best application of your approach?
I'm sorry, sir. In which kind of
patients?
patients? At present, we have been doing mostly musculoskeletal cases, but there have been increasing stroke patients as well. But these patients are actually community-dwelling stroke patients already, mostly in the subacute and chronic phases of stroke.
Thanks. Other question?
Yes, ma'am.
Really interesting presentation. Thank you very much indeed.
Thank you very much,
Thank
too,
you.
ma'am.
I'm interested in the attitude of people to having computers within their own homes. We find in the UK that quite a lot of older people are concerned about having technology in their own homes.
Okay. In contrast to popular belief, ma'am, we in the Philippines have actually more elderly patients already equipped with gadgets, with phones, and then they're on social media. Even our parents and grandparents are into Facebook.
That does surprise me.
Yes, sir.
I'm Bas Subramanian. I'm a rehabilitation consultant in the UK, and we started in 2003 working in the field of spinal cord injury and telerehabilitation, and we had the same concern that the lady expressed about whether people would accept. So we carried out a qualitative study, and we were surprised to see how much people adopted and liked it. And we also did two surveys on SurveyMonkey, and we got overwhelming sort of approval for this type of technology in the UK, and essentially.
That's right.
I'm Dr. Nirmal Surya. I'm the Regional Vice President of WFNR Asia. So what is the situation in Philippines is exactly the situation of most of the developing world, like India and others. So what I gather is what we have an advantage is telephones. So almost everybody in India has got phones. A similar situation would be there. And most of them have children who are very technically savvy on Facebooks and Skype and WhatsApp. The WhatsApp is the biggest savior in our countries. And most of the people can do video on that, and even iPhone. So we have been using that very effectively. And as a matter of fact, when we'll talk tomorrow, how we have used the telephone in the rural camps, in the rural area, while doing another neurological camp to the advantage of telerehabilitation. So it's possible, it's just a matter of thing. And I think we, being from the, as he said, Filipinos mind, we being from lower middle income countries, we are always innovative how to maximize the use of fund. And by the way, what you said, 2 MPBS, this is 5-year-old. Now India has 50 to 100 MPBS. Thank you.
I stand corrected. Thank you very much.